All right. Thank you for joining us tonight. Um, it is our pleasure to kind of get together and hopefully address some of the burning questions out there about careers in neuromuscular medicine and electrodiagnostic medicine, particularly for our trainees who are in a PM&R based program. As people probably are aware, that neuromuscular medicine fellowship is now available as a board certification for PM&R trained specialists who choose to pursue that extra training. But much longer than that, there's always been a long history of PM&R doctors in neuromuscular medicine in various angles, including electrodiagnostics, including care in some areas of neuromuscular patient populations as the main provider, as well as a scientist. So the goal of the session here, I think one of the issues that's come up over and over again amongst the group of us here in our conversations is that a lot of people are reaching out, even from places that are fairly far away from where we are based, with questions about careers and mentorship in the field. So we're hoping to bring together a group of faculty, create a really interesting interactive session here for people who attend live, as well as have a resource that's posted online for people who have questions in the future, just so everyone's dealing with more of a level playing field in terms of having an idea of how to pursue this really fascinating and I think probably we'd agree the best subspecialization possible for a PM&R doctor. And with that said, we have a rough agenda tonight, but there's going to be fairly informal in terms of the panelists just taking questions on and us having a more of a conversation format. But we're going to start with something a little more formal. I have Dr. Zach London from University of Michigan here, who actually is a residency program director in neurology, but also has a subspecialist in neuromuscular medicine and a lot of interest in the neuromuscular match, and has actually been studying and helping improve the neuromuscular match process. So he could give us a little bit of insight in terms of the current iteration of the match for anyone who's thinking about an application, which is just a few weeks away.
Yeah, thanks, Colin, and thanks everybody for joining us tonight. I'm really excited to be here and really thrilled about the possibility of seeing more PM&R residents enter this field. I just wanted to give you a little bit of background of how we got to where we are and what the future holds for sort of the neuromuscular medicine recruitment and application process. So I should also just, by way of introduction, say I'm the chair of the AANEM's fellowship committee. And so our charge has been to sort of standardize the timeline of the fellowship match and create an application portal. And of course, encourage people to use all of those things. So this all stems from what before 2021 was really sort of the Wild West in this field, which is that the application process was without a match, without any sort of organized timeline whatsoever. And what you'll discover, and I'm actually going to show you some statistics on this if you're interested, neuromuscular medicine has been and still is kind of a buyer's market, meaning there are more, you're the buyers here. So there are more positions than there are applicants, at least historically there have been. And because of that, programs that wanted to make sure that they had fellows would start interviewing people and trying to sign them earlier and earlier and earlier. So like the process sort of moved from like mid to late PGY3, which is what it was when I was a fellow, to like progressively earlier and earlier and earlier until the point where like people were expected to apply at like the beginning of their PGY3 year. And I don't know how it is for PM&R at our neurology program, and at our PM&R program, a lot of residents haven't done hardly any EMG by then or any exposure to neuromuscular medicine. So how can they be expected to make a decision? So I think a big part of this was to standardize the timeline and push it as late as we possibly could. And that brought us to eventually sort of our current timeline, which is people being allowed to view applications and start offering interviews in March of the PGY3 year. But see, the other problem pre-match was that, again, programs were trying to get fellows, and so they would often offer positions right away too. So you would interview and they'd like you and they'd say, we'd love to offer you a position, which is fantastic if you want that position. And if you're not sure yet, or if you haven't finished your interviews, it really creates a lot of unfair stress for the resident. So a match really does away with both of those problems because we can fix the timeline We can control it to be whatever we want, and we have a guaranteed gap between when you submit your application, when you do your interviews, and when you actually are getting your offers. And so I'm sure a lot of you have mixed feelings about matches, having gone through it in residency, but I would say really the purpose is very strongly resident facing. I mean, this is meant to make this process more professional and more predictable for you guys. So we started really a formal match last year. I'm not going to talk too much about what we did in 2021. It was sort of a half match, and it was sort of a half success too. But this last year, we did a formal match, and it was through the AANEM. Now, you're used to matches being through the NRMP, right, with ERAS being the application portal. There's another one called SF Match, which some fellowships and other residency programs use. The AANEM wanted to take this on themselves for two reasons. One is that it's free, so no charge to you, no charge to programs. And two, complete control over the timeline. So if you use ERAS, for instance, like the application cycle has to be about 3 to 4 months earlier than what we wanted to do. So the AANEM basically just said, we're going to just do this ourselves. And they created an application portal where everybody can submit all their application materials and then actually have the match algorithm built into it as well. And I wanted to share just a little bit of data from how the match went this last year. So there were 56 neuromuscular programs offering 98 positions. So most programs have one spot, and then some have 2 or more. There were a total of 94 applicants. And while those numbers look very close to each other, this is actually a little bit misleading because, and I'm not sharing this entirely with you, there's another type of program called clinical neurophysiology, which is only open to neurology residents, that they went through the same match. And so some of these people were actually applying to both. Of those 98 neuromuscular positions, 81 were filled, which means, you know, you can see here, there were some unfilled programs too. But I thought this would be interesting to you too. Basically, half of the applicants for neuromuscular got their first choice, 76% got one of their top 3 choices, and the average rank where people ended up matching was a little less than 2.5. So that's of all comers, both neurology and PM&R. So if you're interested in doing this, if you're interested in going through the match, here's basically the timeline of what it looks like. So the AANEM has a website where programs can go, and they're going to put on their website some basic program information. It's going to include whether they're interested in neurology or PM&R applicants, adult applicants, child neurology applicants. All of that will be right there front and center on the site, so you can kind of see which programs you should be paying attention to. And they're sort of populating that right now. And our goal is to have, again, every program, every neuromuscular program in the US participating. Last year, we got, I think, 54 out of 56 did. So we're trying to get 56 out of 56 this year. And then basically in January, you're allowed to start entering your application materials into the portal. So this is, you know, just basically filling out usual application stuff and submitting letters of recommendation and things like that. But here's the thing. January 1st is not your deadline, because between January 1st and March 1st, nothing happens. No one is allowed to look at your applications before March 1st. So when you're trying to think about when do I actually have to decide I want to do this, when do I actually have to have my application materials submitted, I would say a soft deadline would be March 1st, because that's the first day that anyone could actually look at your application and offer you an interview. And then interviews basically take place through May. There's actual rank list submission, just like there was when you applied for residency. And then there's about a week between the rank list submission and the actual match day, where we can basically run the algorithm and then double check and triple check to make sure everybody is ending up where they wanted to. And I would just say this year that worked perfectly well. We were a little bit nervous because, again, this is the first time we had tried a match, but everybody sort of ended up at the highest ranked place that wanted them. And so we're continuing this year, and the application cycle will be the same. And we look forward to many more successful match cycles.
That was great. Actually, you know, for a few of us who just missed out on the beginning of the match, that was really instructive about how it's working. And and a little bit of the backstory about why we are the way we are. And I can add one thing that's really great this year too is the website on the AANEM website. You can actually see if programs are considering PM&R applicants. And I think just asking that question as may even be motivation for more of the programs to support PM&R applicants, actually, to have that listed on the site. But you can see that, and that brings to mind now, like introducing some of the panel members and a conversation I had recently. I have an order here, but I'm going to break my order that I sent everyone because it reminds me of when I was speaking to Matti Allen, who's he's actually Canadian. He's up in Ottawa, and I'm sorry, I keep saying Ottawa, but Kingston, Ontario, Queens. I've said this several times to him. I don't know why. I mean, I should know better because I'm Canadian too. But Matti, why don't you tell us a little bit about your story, your inspiration for doing a fellowship, and tell us where you're going to be going next year to start your fellowship and what it was like, with the whole process here.
Sure. Thanks, Colin. Hi, everybody. Nice to be here. My name's Matti. I'm a fifth-year resident in physiatry at Queen's University. That's in Kingston, just south of Ottawa in Ontario, Canada. In Canada, we do 5-year programs, so this is my final year. And next year, I will be very excited to be joining the Ohio State University for my neuromuscular fellowship. I was pretty pumped for that. And in terms of how I got here, so before medical school, I did a master's and a PhD in neuromuscular physiology. It involved a lot of EMG work, especially quantitative EMG. And so when I applied to medical school, it was actually with the idea that I'd end up in neuromuscular medicine from the get-go. And then, although I enjoyed all the different things I did in med school and clerkship and all that, nothing really came close to changing my mind. So at this stage, I'm hoping to end up in sort of the academic side of things, being a clinician scientist at the end of the day. But I think maybe I'll leave it at that, and looking forward to answering your questions.
Great, thanks, Matti. And then I'll go to the other person who's been recently and has definitely been through the match cycle, which is Adewuyi or Nike. And Nike, who's currently a neuromuscular fellow at Northwestern. Do you want to tell us a little bit about your story, how you got into this whole thing, and your inspiration?
Sure. Nice to meet you, everyone. My name's Nike. As Colin mentioned, I'm currently a neuromuscular fellow at Northwestern University. And before I tell my story, I will preface this by saying, because Matti went first, you do not have to have a PhD to go into neuromuscular medicine. But I guess before med school, my background had been in engineering, and I actually went to the MSTP or MD PhD program at Northwestern. And my PhD was in neural engineering, where I also work with EMG, but using it to control prosthetic devices using sort of advanced machine learning algorithms. And went into PM&R. I actually was deciding between neuro and PM&R, but ultimately chose PM&R. Initially thought I was, going to do general physiatry. I had worked with amputees. I was like, that's population I'm going to work with. Did a second year, PGY 2-year, like stroke and TBI. So I thought I was going to do TBI. And third year was when I started our EMG rotations. And I was like, oh, I really like this. It wasn't until sort of later on in my PGY 3-year where I did a neuromuscular rotation and saw the clinical side of it. When I decided that, well, this is something really interesting that I wanted to do. There are the research aspects that interest me. I like the patient population. I love working with EMGs. And so decided to apply into neuromuscular. The year that I applied was kind of the half match year. And what I mean by that is typically when we think of a match, you rank and then the program ranks you. But this particular year was the first year they were trying it out. And so as an applicant, you didn't have a rank list, but the program had a rank list. And then they would, offer you a position, you'd accept or not accept, and, go to the next institution if you didn't accept. So it was, kind of a mix. So a little bit different from what it is now. And I'll just end there and I'll take your questions later.
Perfect. And, it seems like we're on a run of people who did the neuromuscular medicine fellowship, but that's not the only way to do things. And so it just sort of strikes me maybe to get a little bit of balance here, because we're going to be exploring this from different angles. Maybe we could have Dr. Howard and representing some of our West Coast affiliates here. Yeah.
Sounds great. Thanks, Colin. Hi, everyone. My name is Ileana Howard, and I work at the VA Puget Sound based here in Seattle, Washington. I stumbled my way into neuromuscular physiatry. I did not do a fellowship. I love how Dr. London referred to the time before 2021 in the match as the Wild West. And if that's true, then I'd consider myself an early settler on the frontier of neuromuscular physiatry. Because there were very few people before me who had ventured into the field. And although I was lucky enough to train as a student under people like Lisa Kravickas and Greg Carter, similar to what Nike said, I loved everything about PM&R, all aspects. And so after I finished training 14 years ago, I took a job as a general outpatient physiatrist at the VA. At the same year that ALS became a service-connected condition at the VA, and it was because of a surge in demand that my career evolved over time, and I found that neuromuscular physiatry was truly a passion for me. And so my clinical practice now focuses on neuromuscular PM&R and EMG, and I agree with Dr. Franz in that I think it's one of the most rewarding subspecialties, and obviously with the best company and colleagues of any of the subspecialties in PM&R. So I'm happy to share my perspective of what it's like going into this subspecialty without fellowship training, and whether, if I had that opportunity to go back again, whether I would choose to do a fellowship. And I think it probably depends on what your career ambitions and goals are. And so happy to have that conversation as part of our discussion or at follow-up anytime after this forum. Thank you all for being here today. It just warms my heart. I have a lot of hope for the future of neuromuscular physiatry. I think that there are a lot more questions than answers, and there's room for every single one of you to join us.
Great. Well, I guess now that we're kind of hearing about people who didn't do a neuromuscular fellowship, I just thought, well, there's some people who did fellowships, but then still found their way to neuromuscular, which, because I think they saw the light. That makes me think of Dr. Mosher in Ohio.
Thanks, Colin. I'm Kathryn Mosher. I'm a pediatric physiatrist, and I work at Akron Children's Hospital, just north of the Ohio State University. And I did my combined residency in pediatrics and physical medicine rehab at Thomas Jefferson University. And I was really inspired to go into this field by my mentor, Gerald Herbison. Some of you may remember him. He retired about 5 or 6 years ago, but he was a phenomenal educator in electrodiagnostics, did many sessions for PM&R and AANEM, and was a recipient of the Lifetime Achievement Award. But his first love was pediatric neuromuscular. And so through that connection, he gave me valuable connections to the pediatric neuromuscular world. And when I started my career at Akron Children's, I was asked to develop a multidisciplinary neuromuscular program, which has been just a joy for me to do. And I'm very proud of what we've been able to accomplish. And I would just say for anybody who has an interest in pediatrics, this is a really, really exciting time to be in neuromuscular pediatrics because we're seeing breakthroughs in treatments that actually change the trajectory of children's lives. And that is a very rewarding thing to be able to be a part of. Just about 6 weeks ago, I would say, I had a patient with spinal muscular atrophy type 1, which, as you may recall, is typically a fatal disease, usually with a life expectancy of about age 2, oftentimes on a ventilator with a G-tube. And this young lady, who is 2.5, walked down the hall to get away from us because she's afraid of physicians and hospitals. And it was the most beautiful walk away from a physician I have ever experienced, and I was just delighted to witness it. So we are in a position to really change history through the things that we can offer families. And I was also really encouraged to hear that AANEM is actually trying to reach out to pediatric neuromuscular physicians to help promote the field. So I'm happy to answer any questions people have.
Great. And then I guess in the continuity of people who do 2 residency programs or combined training, makes me think of Dr. Ensrud, who's joining us also from the Midwest, Missouri. Dr. Ensrud, do you want to introduce yourself?
Yeah. Thanks, Colin. I'm Erik Ensrud. I'm at the University of Missouri, about halfway between St. Louis and Kansas City. And I am both a physiatrist and a neurologist. I chose to do that based on positive experiences and the availability of a combined residency at that time. But I actually went into it planning on going into TBI. And during that time, I was our residency, I was at Spalding, was a standalone rehab hospital rather than an integrated unit in an acute care hospital, which is very different than I'd experienced as a medical student. And my interest in TBI waned, and I was looking for something else. And I was fortunate. There are some people in the generation before me. I think they've already been mentioned. Lisa Kravickas, I got to know, and Greg Carter, and I decided to do neuromuscular fellowship. And my training was with a guy, Anthony Amato, who was always very positive about neuromuscular physiatry. And so right from the get-go, it was easy to be accepted, and he's continued that. There's always PM&R physicians in that fellowship, but I have really enjoyed it, and I'm so happy to see something like this we're doing tonight. For years, it was tough trying to get more neuromuscular interest, and the AAPM&R really worked on that, and we kind of got joined at the hip with pain medicine, which is kind of an interesting pairing, although it turned out to be great. I've met so many great physiatrists who I'm friends with in pain medicine, but I just think there's a real, there's just so much that physiatrists have to offer to neuromuscular patients that I am very excited about more and more people being interested in pursuing the practice of neuromuscular medicine.
Right on. Yeah, actually, I did comment a few times during my fellowship that I felt that neuromuscular neurologists were the most in tune with, I think, rehabilitation out of any of the neurology faculty I worked with because it was such a big part of their interdisciplinary formats. So we've got 2 more people to introduce. So how about we do the protege, and then we finish with one of my best friends in all of physiatry, Dr. Radlas. So Dr. Kai, did you want to go first?
Sure, I'll go first. Hi, everyone. My name is Daniel Kai. I recently started as an assistant professor at UT Southwestern in Dallas, Texas. So I did medical school and a residency in PM&R at UT Southwestern. I did a neuromuscular fellowship up at the University of Washington with Dr. Rad, and I just recently started as faculty here, I guess a little over a year ago. I really like what Dr. Howard said about stumbling onto this field. I feel like as a resident, as like a PGY2, I liked everything. I liked general physiatry. I liked inpatient rehab, but I didn't really know where my career was going. And then I did the EMG rotation as one of the rotations of PGY3 year. And that's when I feel like I really found my passion. One of my mentors told me to, if you like EMG so much, why don't you try doing a rotation with the neuromuscular department, see the kinds of things that they do. So I did a neuromuscular rotation, got to work with the patient population, and really like from there, I knew the fellowship was for me. So, after doing a 1-year fellowship, I started a position where I'm dual appointed by both PM&R and neurology. And it's a position that didn't really exist, before I started this job. But I feel like I've gotten to do really meaningful work with both departments. On the PM&R side, I get to work with, these complex neurological diagnoses. I get to teach residents about how to do EMGs with a more neuromuscular focus, as well as neuromuscular ultrasound. And working with the neurology department, I get to handle the rehab aspects of their patients, wheelchair fittings, some of the more MSK issues, joint injections. So it feels like working with both departments, everything I do is very impactful and very meaningful. So I'm very happy with where I've ended up. And I just want to echo that, this is a really exciting time to be a neuromuscular physiatrist. We're having more and more patients with Duchenne's and spinal muscular atrophy live, longer and better lives than before, but they're going to be needing a lot of rehab care throughout it all. And I'm happy to answer any of your questions.
Great. And Dr. Rad.
Thank you, Colin. It's a pleasure to be here tonight, surrounded by such wonderful colleagues. I completed residency and was privileged to do so with Colin at the now Shirley Ryan, back then just RIC. And for me, neuromuscular fellowship I was drawn to it based on patient population. So rotating through the various specialties in rehab, I came across our inpatient unit that took care of individuals on vents. We had a good amount of neuromuscular patient exposure on inpatient. And it was this patient population that I knew immediately I wanted to work with. I love the connection to the families. In some ways, I would say I remember on my inpatient rotations that I kind of felt like their primary care physician. And that that wasn't a great thing to a lot of residents, but I really enjoyed the fact that we were taking care of multiple systems. And I was drawn to go into fellowship because I wanted to have a better understanding of the diagnosis. I wanted to have a better understanding of management, inclusive of rehab. So many of these diseases change over time, and I wanted a better idea of that. As Dr. Kai mentioned, these diseases are evolving with new disease modification treatments. And as rehab specialists, we're really, really fortunate because those of us with an interest in neuromuscular disease and those of us who are involved in their care are going to be the ones providing a majority of their care after diagnosis. And so I wanted to make sure I had a good understanding of that. In addition to that, I also came across a lot of patients that would come with a known diagnosis and that weren't really adding up. And so the ability to make sure that they were properly diagnosed and we were doing appropriate management meant that I needed to have a good understanding of when people needed to, have reevaluations. I love DMGs, and so I love the procedure aspect of it. But for me, it was really patient population, and in that, with that being the most important thing to me when I came out of fellowship, I ideally wanted a job that worked in a multidisciplinary clinic, and I was fortunate to have found one at the University of Washington. And so I get to work with colleagues like Dr. Howard across at the VA, and so I'm surrounded by wonderful PM&R colleagues and a wonderful neurology department as well. And so oftentimes the neurology neuromuscular group tells me, they don't see neurology or rehab, they just see neuromuscular. So we are the neuromuscular specialists, and we operate as a team together. Being a part of that team allows me, as several has said, to, take care of whether it's the rehab needs of those diagnosed. I do continue to diagnose patients and co-run the ALS clinic and run the SMA clinic, but it also allows me to take part in clinical research trials with the neurology department, something that not every rehab program does. And so you're able to utilize many colleagues. And so I'm happy to be here, happy to answer questions about, why one would want to go into a fellowship and what opportunities that leads you into.
Great. I guess I'll briefly say I benefited from the Wild West format myself. I was a co-resident with Dr. Red, and I was looking for jobs and sort of knew I wanted a neuromuscular focus. Didn't quite know if I could handle adding another year onto already a lot of years of post-training education. I'd done a research year too, but ultimately I was just so interested in it. And when I was sort of waiting for the right job, I just kept talking to the fellowship director at Northwestern, and then I just said, what, I'm going for it. And I just listened to, just like usual, just took the harder pathway in the sense that I, added more training that I seem to always sort of choose over the more practical sort of thing, which is just get a job and start paying down your loans. And I haven't regretted it at all, just because it's given me a couple of things. One, I'll say it gives me a little more credibility, starting out. I was trying to establish myself, that people, were willing to send me referrals and build a neuromuscular practice. So I got to see, a lot of the patients I was interested in. I got involved with the ALS clinic at Northwestern, and and I see patients alongside of and parallel to the neuromuscular neurology faculty there as the only PM&R neuromuscular faculty in the group. And then I do research, but I saw one of the questions. I'm just going to take one of them out of the I think Dr. Howard might be tackling it too, but you definitely don't need to be a researcher to do a neuromuscular fellowship. I see that that came through, but I think that because there's we talk about regenerative rehabilitation, at the AAPM&R meeting, and I keep thinking, the real regenerative medicine to me is gene therapy for SMA. It's gene therapy for Pompe's disease, these or enzyme replacement. And that to me is the reason there's so much emerging with genetics, with neuroimmunology, that things that we can do for these patients, that it does sort of pull you in, even if you're not going to be a researcher, but to stay up to date with the constantly changing toolbox of treatments and things we can do to modify the illnesses of the patients we're taking care of. So no, you don't have to be a bench scientist, but I think you really do need to, enjoy staying up to date with the literature, because things are changing quickly and in an exciting way. So with that said, I figure, well, we've got a lot of questions coming in. There was a question about what is the difference, and faculty, what I'll have you do is there's a little a reaction sign. I believe you can just raise your hand, or if you can't figure that out, just raise your hand, literally raise your hand, and I'll try to call on people for some of the questions. Some of the questions I'll just direct to people where it's appropriate. But there's a question: what's the difference between neuromuscular medicine and electrodiagnostic medicine? Does someone want to take a stab at it, or I'll call someone out for that one? Did I see Dr. Rad move? Maybe she's just scratching her nose. But why don't you
I did, but I can't. Yeah, I was, but good. So, and I think Dr. London also in his introduction had mentioned electrophysiology as part of some fellowships, and so I'll dive into that as well. So electrodiagnostic medicine, and somebody can correct me if I'm wrong, is not in and of itself a fellowship. And I think this touches on somebody else's question on, is there just a fellowship in electrodiagnostic medicine? And there's not a formal one, to my knowledge. Electrodiagnostic medicine is a portion of practice, and some, practitioners may only do EMG, but that's something that they chose. Neuromuscular medicine is a specific subspecialty of neurology, and I'd like to say rehab medicine, although the fellowships are in neurology, and it incorporates the diagnosis and management and treatment of neuromuscular disorders. So, from anterior horn to muscle disease. As part of the diagnosis includes electrodiagnostic medicine, and that's why EMGs are part of that fellowship. But it's really a portion of that fellowship. Some of the fellowships that do neuromuscular medicine also include electrophysiology. Those we would not be eligible for. You'd be reading EEGs. But I think those have been, will be, kind of separated out. And I'm going to quickly tie in, somebody asked, like, what percentage of, of fellowships are EMG versus clinic. I think most of that depends on the program. In my personal experience and from talking, to colleagues, it's usually about 50-50. That might not be perfect. It might be 60-40, but there's usually a fair amount of both.
That said, what percentage of your practice is EMG is an interesting question for some of our more experienced, I won't say our older, but our more experienced faculty. And they're just like looking at it here, Dr. Ensrud typed an answer in, but I'm not sure everyone in the audience would have been able to see the answer question, but maybe you could talk about the composition of your practice and how it ended up that way.
Currently, I'm about 40% EMG and 30% neuromuscular clinic, meaning general neuromuscular or non-diagnosed neuromuscular MDA clinics and ALS clinics. I think one thing to realize, EMG tends to be one of the more enjoyable procedures in that you can talk to patients while you're doing it. In fact, I've always encouraged residents and people in training to talk because it helps distract them from the less comfortable aspects of the procedure. And then, just about everybody, I'm not going to sound totally oblivious, but just about everybody is very interesting if you ask them the right questions. So I've just found that to be such an enjoyable part of practice, is talking to people while doing EMGs on them. And then an important thing for you to realize is the time you spend doing EMGs, and I'll stop here, doesn't create downstream work for you, or very little. Whereas seeing patients in clinic, particularly patients who have significant physical and other needs, creates a lot of work between the visits and so on. So it helps kind of balance out your practice and your time to do both.
Maybe Dr. Howard, did you want to add a little bit about your breakdown of your practice and EMG versus clinic?
Sure. My response that I typed in is that it's very fluid and it's ebbed and flowed over time. Right now in my current practice, I have a national role as the chair of the ALS Executive Committee for Veterans Health Administration. And so my current practice breakdown is about 60 to 70% administrative because of the rollout of our national ALS system of care directive. And so I think that it's lovely to maintain those tools for EMG and to be able to balance out the heavy neuro rehab clinics with the lovely procedural clinics with EMG to have that balance, just like Dr. Ensrud said. So yeah, I've gone between, oftentimes 50-50 to now I'm more clinical with less EMGs while I'm serving in this administrative role.
Does anyone else want to add anything on that before we move on to another question? Okay, I'm going to ask the question that was pre-submitted now, which is, you PM&R residency, you're required to do 200 EMGs. So why do you need the extra training in order to have a focus on neuromuscular medicine? Why do you need the fellowship training as opposed to just the PM&R residency training requirement? Does anyone want to touch on that one? And I'm going to prompt Dr. Kai, since Dr. Kai is a recent graduate from a fellowship.
Sure. I think that's a question that that gets asked a fair amount. And I think it kind of depends on what you want to do in your clinical practice. So the Neuromuscular Fellowship adds not necessarily a greater quantity of EMGs, but more so a more variety of the EMGs like ALS or myasthenia gravis or CIDP, which are traditionally more skewed towards neurology at most academic institutions. So I think after a fellowship, you feel very comfortable with those types of traditionally neurology EMGs. Being a physiatrist, you're going to have a really good understanding of the peripheral nervous system and musculoskeletal. So you're going to be able to do carpal tunnels, radix, traumatic nerve injuries very easily as well. So if you want to be a very well-rounded electromyographer, I think the fellowship helps quite a bit with that, as well as if you want to work with doing rehab issues for the neuromuscular patient population. I think the fellowship helps with that as well. But if your goal is you just want to do a more generalized MSK practice, you want to do a lot of carpal tunnels and radix, then you might not necessarily need a neuromuscular fellowship for that.
Does anyone else want to add to that?
I think it really adds a lot in terms of understanding what you're finding on the EMGs, because the Neuromuscular Fellowship is really about the diseases. And there aren't a lot of PM&R or neurology programs for that extent, because it's not a highly inpatient diagnosis that really cover the neuromuscular diseases in depth. So I think that residents from either specialty can gain a lot by doing a neuromuscular fellowship.
And then pivoting off the fellowship question and EMGs, what about the possibility of being in a rural practice where you're going to have to just see more patients with a broader set of diseases, potentially be one, if not the only, subspecialist in this area? Does anyone want to comment on, being a neuromuscular trained physiatrist in a rural area, not necessarily fellowship trained, but with or without fellowship, what a practice might look like? And I know that was answered in the chat. I think maybe we could get Dr. Howard to comment it, or Dr. Mosher as well, either or in whatever order. Maybe Dr. Mosher take the first crack at it, and Dr. Howard has an answer in the chat already. So why don't we do that?
Yeah, so I think it's an interesting question. And I think, there's definitely an access issue in terms of care for patients with neuromuscular diseases. I think the challenge is having adequate patient population to support your interest. And so I think the advent of things like telehealth could really help to be able to be successful in a rural environment where you're closer to patients who may have less access, but you also can provide consultation to people who may have trouble getting to you. So, I'd be interested in what Ileana thinks too, but I think for some of the things that are coming out in terms of treatment options, it's really would be difficult to offer some of those things in a rural setting. Some of them you can for sure, but some of them you're going to have to refer to a larger institution.
Yeah, I would love to build off of that. Access is a terrible problem in neuromuscular medicine. In my clinic, I use telehealth to cover a 2,000-mile radius of patients from the Hawaii Islands through eastern Montana, and I would love to have help with more physicians trained in neuromuscular medicine that could see those patients instead of trying to cover the gap through telehealth, because we know it's an incredible tool, but it can't always replace hands-on care for these individuals. I have also had the misfortune of reviewing EMGs from more rural areas in our state, that because of the shortages of well-trained physicians who have background in electrodiagnostic medicine, the gap is being filled by non-physicians who are doing EMGs and diagnosing patients with neuromuscular conditions, and that's unfortunately doing a disservice to these patients, where critical treatment decisions are being made based on those electrodiagnostic studies. So there is a great need. The colleagues that I have in those rural areas have backlogs of 4 to 5 months to get in for EMG studies, which indicates to me that there is a great need.
And I just was pointed out to me, by the way, that that the questions that we're answering in the chat are only going to the person who asked it, not to the whole audience. So we'll make sure we cover all the questions, but we can still type them in. I'm keeping track. Okay, so thank you for pointing that out to me. I will take us to another question about what does a strong applicant to a neuromuscular fellowship program look like? I'm paraphrasing here, and I thought I'd take this one to. Oh, someone said if you go under the answer column, they can see I think you can go and then find the answer. So thank you for clarifying that. But we'll still try to repeat and sort of conversate about a lot of the questions that are coming up there. Dr. Rad, why don't you tell us what a strong applicant looks like? You're now a seasoned veteran.
Is going to pull Dr. London into this one as somebody who, is running or seeing applicants. But I have been able to interview a few of the, applicants as they go through this match process, and have sat down with the colleagues at the University of Washington. And, one of the things that comes up is exposure to neuromuscular medicine. And this is, both the neurology and rehab residents, because a lot of times we'll get applicants in who have never, done an EMG or shadowed an EMG. And so I think having good exposure to neuromuscular medicine and understanding why it is that you want to do the fellowship is really important. Having the ability or the interest level in terms of, self-education and curiosity were some of the things that came up from various of my colleagues interviewing individuals, people that seemed enthused about the field. I don't think this is necessarily unique to neuromuscular medicine. Also, an interest in, I think actually, Colin, you had mentioned this, staying up to date in literature. This is a field where you don't necessarily need to, as you mentioned, actively participate in research, but the field is ever changing. And so making sure that you're somebody that's going to stay up to date with that. I think across the board, something that I have told rehab people nervous about interviewing in the neuromuscular field is that not all neurology residents have exposure to neuromuscular before they apply. So a lot of times, here at the University of Washington, sometimes we'll get neurology residents that are on an elective and they're on vacation for half of it. And so I think in that sense, the rehab residents shouldn't be intimidated by that. But making sure that you have a good understanding of what neuromuscular medicine is and a good idea of why it is that you're interested in.
All right.
Dr. London may have more to add to that as somebody who's seen these applicants.
Sure. I mean, I think, most programs are going to be trying to look pretty holistically at what you bring to the table. And I feel like you touched on a pretty important point, which is there are differences between the experiences of the neurology and the physiatry residents beforehand, but they're very complementary. And so the neurology residents are going to have probably a little more experience with things like immunotherapy, but they're going to have less experience with EMG. And certainly the things that a rehab doctor brings to a clinic visit that your neurology attending is going to lack. I can speak as one of those attendings, is extremely helpful to have those skills, to have those skill sets in your clinic. So, I think a lot of programs are actually probably trying to look for sort of balance and sort of, how you can complete the puzzle of what they have. So, and in general, it's the same stuff that they're going to be looking at when they're looking at any other application, which is letters of recommendation and, personal statement and that sort of thing. And your enthusiasm and, clinical abilities in general.
And Dr. Kai, you wanted to add something?
Yeah, I just wanted to, add to the point that Dr. Rad and Dr. London made. I think, one of the big barriers of having more physiatrists in neuromuscular is that all of these fellowships are through neurology. So, especially as a PM&R resident, it's a little intimidating to, apply to these programs if no one in your residency has done it before, or you aren't too sure, how you would compare to a neurology resident. So, I completely agree with Dr. London that, neurology residents and physiatry residents, bring in different skill sets that are complementary to neuromuscular medicine. I think as a physiatrist, you're going to have, an experience of at least 200 EMGs. Neurology residents don't really have any formal ACGME requirement for EMGs. So you're going to have a lot more experience there. You're going to have a lot of experience with, the rehab aspects of, taking care of these patients. You're going to have a lot of experience in, knowing the peripheral anatomy, taking care of a lot of these diseases. So there's a lot of value that you would bring to a, fellowship program.
Yeah. Why don't we switch to a new topic? Thanks everyone for their insights. I'm going to direct this to Dr. Allen, and then we're going to go to Dr. Adewuyi. First, Dr. Allen, I want your perspective going into fellowship. What skills are you kind of hoping to pick up in fellowship? And then Dr. Adewuyi, who's in the midst of fellowship, can tell us what skills she is picking up and what are the things that are enhancing her toolbox.
Sure. Yeah, that's a good question. And I think it kind of speaks to one of the answers we're having earlier about why you're choosing to do the fellowship. So in terms of skills, I'm hoping to get a lot more exposure to the entire breadth of neuromuscular medicine. I've had a chance to do maybe 4 or 5 blocks of neuromuscular medicine with neurology departments over the course of residency, but I still find that you're only seeing just the tip of the iceberg. And I think a full year of being in those types of clinics kind of gives you that chance to see the whole spectrum and have a greater comfort, a greater sort of clinical acumen and sort of understanding and appreciating some of those clinical presentations. And then along with that is some of the electrodiagnostic tests that that as a resident I'm doing very infrequently, whether it's a I don't do, just for in my center, I don't do a lot of facial studies. I don't do a lot of blink reflexes. I don't do very much single fiber EMG. So those are all electrodiagnostic skills I'm hoping to buff up. Another thing that I found had a lot of heterogeneity across programs was some exposure to neuromuscular ultrasound, which no one is really doing at my center where I am up here in Ontario, Canada. But it's become sort of more in vogue in the last 10 years or so. And I wanted to go to a place where I could get a lot of repetitions and some expert mentorship in picking up that skill. The other thing that I won't maybe go on at length is, as someone who is interested in sort of the academic side of things, I'm also really keen to be at a place where I'll have some mentors who can add to my research toolkit and help me sort of build that career that's what I'm looking for. And that might not be for everyone, but I think that's just sort of the things you sort of start to consider in terms of when you're picking where you'd like to do fellowship, are what are the goals that are really important to you, and then making sure that they line up with your rank order list at the end of the day. I'll pass it over to you, Nike.
All right, and I think I'm answering what I'm learning right now, which also partly answered why I do a fellowship after doing, a PM&R residency. And well, Matti, you touched up on a lot of those from the procedural standpoint. You've learned your carpal tunnel, your disc screen. You guys can do that with your eyes closed and seeing that variety and getting better at the more obscure, facial muscles or whatnot. I'm learning that. I think just this past week, I did 2 single fiber studies, which I was really excited about. I actually saw some jitter. We diagnosed this patient with myasthenia. So that was exciting. And so there's that. And then there's some other, skills that you learn, which you could spend some more time to if you're so keen to. Things like muscle biopsies or autonomic studies, which I feel like are generally less well studied, but that's also something that you can learn and expand upon during your fellowship. And then there's some fellowships that will also do focus on neuromuscular ultrasound. I think the big part for me is on the clinical aspect, seeing diagnoses that I hadn't seen during fellowships and managing these. So coming from the PM&R side, right? What are these, the immunomodulatory treatments for autoimmune conditions, either myasthenia gravis or like an inflammatory myopathies. So that's sort of, a big part of what I'm learning. And then there are just many other diagnoses, learning about the genetic aspects, which we don't learn about during PM&R residency. Yeah, does that answer the question, Colin?
There's no absolute right or wrong. But one thing that's come up in one of the recent questions, and I think that bears addressing too, you both hinted at it, is neuromuscular ultrasound. Does anyone want to take that on in terms of, because it's not uniform across the country and across programs in terms of how much exposure you get. So if this is something people want, you're going to have to look closely at the programs, who's there. You're going to have to ask a question if you interview. And there's like 1 or 2 questions on the boards right now, usually on ultrasound, but not tons. Dr. London, you might maybe more tuned into this than most, but could you comment on that? Like, because I suspect we're still building up faculty with enough skills to actually teach it, to make it a standard for all programs to have a lot of neuromuscular ultrasound. There's also other ways to get that training, but could you comment on what's the landscape for programs?
Yeah, I would guess that somewhere between 25 to 40% of programs, I would say, have that as a significant component. I'm just sort of spitballing here. Maybe those of you who've been through it more recently could comment on it. And I think that number is growing. And I think when you go to the AANEM portal and look at the programs little splash screens that they put up there, it will definitely have that information, because the programs that are ultrasound forward will want to advertise that, because they're trying to appeal to people who are interested in that.
Yeah, I think that's a good point. Is anyone here doing any significant part of their practice with ultrasound? Yeah, go ahead, Erik.
Oh, it's an important addition. I think there are other things that will be, continue to be, maybe more important in neuromuscular medicine than ultrasound, but there's a lot of benefit from it, from focal neuropathies. And, when you're a physiatrist and you practice neuromuscular medicine, you're going to see a lot of patients who have neuromuscular disorders. I think Sai mentioned this already, that have musculoskeletal problems. So if you develop some ultrasound skills as a PM&R resident or in a neuromuscular fellowship, you may be able to use that, which I've certainly had the opportunity, in doing musculoskeletal injections with ultrasound guidance, for example, or Botox with ultrasound guidance. And so it's a good skill to have. It is something that you can develop as a practitioner as well, but it's very helpful to have it. Yeah.
Why don't we go to Dr. Mosher next? I know Dr. Kai was also.
Yeah, so I am in the process as a physician attending of developing that as a skill. So I can sort of speak to that. I'm fortunate that I have a physician that I work with in our neuromuscular program who is fellowship trained, who's generously sharing that knowledge with me. But I think it's really a very valuable tool, is particularly in pediatrics, but I think everywhere, because it's painless. And there's so much information that you can attain in a short period of time with virtually no discomfort to the patient that could really help guide your additional workup and help you get a sense of what you're dealing with even before you have your genetics or your muscle biopsies back. And there's a growing body of evidence that certain types of muscle diseases preferentially affect certain muscle groups. So just in a brief scan, you can really get a lot of information in a relatively painless manner.
Great. Yeah, I do some in my practice, and I will say that I envisioned using it one way. I did the course at Wake Forest. I did a little bit of scanning during fellowship of peripheral nerves, and there was a lot of scanning available to me as a resident, at Shirley Ryan, but it was more sports medicine focused. So, but I think the thing I'd say is you need to know how to hold an ultrasound and figure out the knobs, and then you need to figure out how to scan something over and over again so that you get really comfortable with the process, so that you can start expanding your skill set there. And there's really great courses through AANEM, other courses available that you can find. And for purposes of, if you have an academic job, you need to eventually convince someone that you deserve privileges. So you'll need it's nice that the program can write you a letter and provide you that support, as well as for me, they asked me to take a national level course, which was not to endorse it over other options, but the one at Wake Forest was a fantastic one. But there's other good ones that you can find, and both intro and advanced ones. And the problem with any of the courses is that it's sometimes crowded, so it's hard to get a lot of scanning time at them. So if you don't come in with some skills, it can be a bit tricky taking them. But I needed to do it for the certificate, and there's a certificate of added qualification through the ABEM. That I opted to do partly just to help establish myself with the credibility to continue the practice, because I was early in my career, and I found that to be desirable to have if I ever moved on from my current job, so I could keep using that tools. And we found it to be incredibly useful for scanning neuromuscular patients with diaphragm weakness. So that's kind of become my something I didn't anticipate from the onset, but it's become really useful for ALS. It's become useful for vent weaning and spinal cord patients and other things we could talk about. another time. I'm trying not to answer too many questions myself. I get a lot of time just transitioning from question to question. There's a really good question out there about job market that I think is really important. It was on my list of things to talk about tonight. It's come up at least 2 questions. What is the job market? You finish your fellowship. If you do the fellowship, or, you know, is it ultimately, is it going to give you higher income? Is it going to give you more options? What's the reality of it? Because this comes up, it's a really good question. Dr. Kai, I think, answered in a very excellent to the point question. Darren is recently in the job hunt. I don't know if you want to take that on first, and then we can kind of hand that one around in terms of what opportunities, what challenges there were in searching for your first job.
Sure. So, you know, I did residency at UT Southwestern, and eventually I ended up coming back here to start my attending position. I think I was fortunate that I knew both the PM&R and the neurology department before I started my job. So that kind of, you know, accelerated the networking. You know, they kind of already knew what I brought to the table. But, you know, I think it definitely is a little bit daunting to go into this new field where there's not too many physiatrists doing neuromuscular medicine, and then, you know, trying to go out and, you know, see what the job market is like for yourself. And I think, you know, my advice on that would be, you know, when you're interviewing for jobs, like sometimes I think it'd be, you know, very hard to, you know, like convey exactly what your value is, because what you do as a neuromuscular physiatrist is pretty specialized. But, you know, it's like, I would say just, you know, try to get your foot in through the door. It becomes very obvious what you bring to the table to both departments, like, you know, pretty quickly. When I started off, I did a good amount of general physiatry, but, you know, like very quickly within a few months, like, you know, they start, if you do a good job, they start asking you to do more things. They wanted me to join the ALS clinic. They wanted me to join this multidisciplinary clinic for Duchenne's and SMA. You know, they wanted me to be more involved in EMG education and neuromuscular ultrasound. So, you know, I think, you know, it's like once, like, you know, if you have the skills, if you know, if you want to work with this patient population, like, you know, your value will be evident. And I wouldn't worry so much about trying to present all that value immediately and like finding, you know, the perfect clinics, like, you know, when you're initially looking for a job.
Great. Well, you know, and then from someone who's more established and also, I think, could speak to maybe the lack of, I think you reiterating the point of the lack of sometimes of neuromuscular specialists, and the need for them. I mean, we've been looking for some people, you know, I feel like we're consistently in a job hunt, and it's just so hard to hire people because there's so few people available, you know, when you're searching for people in academic neuromuscular medicine. But maybe Dr. Howard, Dr. Ensrud could comment a bit on it from their perspectives. Dr. Ensrud, why don't you go first, and then Dr. Howard.
Yeah, there is a real shortage of patients, or excuse me, of practitioners who see neuromuscular medicine. And I think, you know, as a physiatrist, you can go in with sort of a go-getter attitude and go to places, for example, that if they're advertising for a neurologist, apply and say, I've got these skills. And I think and I know this from having trained so many PM&R residents and worked with PM&R you know, residents who did fellowships, that they almost universally end up being very well received. And like you said, once you're there, they see what you're doing and appreciate it and so on. So there really is a huge shortage of people in this field, and there's a real opportunity to get us, you know, to get a satisfying job. I don't think you need to, you know, unless you're so focused on one location, you need to be in a specific city, or and they're, you know, unfortunately people are people, and that goes for people who practice neuromuscular medicine too, and there is some territoriality that can be involved, and that's, kind of regretful because it's not patient-centered. But I have Ileana, why don't you take ahead? But people have found really meaningful jobs that have expanded once their skills are recognized. Yeah.
I totally agree with you, Dr. Ensrud and Dr. Kai. And even if you are tied to one geographic area, and I am diehard West Coast, Best Coast, settled in my place and anchored with several children. And the beautiful thing about neuromuscular physiatry is that we are very well equipped to treat a wide variety of patients. And just as Dr. Kai mentioned, if you get your foot in the door, even with general rehab, you can really cultivate the demand that you want, and what calls to you the most in many cases, and build a program where there wasn't one previously by demonstrating the value that you add. And that's exactly what I was able to do in my facility and in launching an ALS clinic where we didn't have one. So I think that there are a lot of opportunities out there, and you might not find a perfect job listing for specifically your role, but I think part of the beauty is in building something from the ground up that's truly yours.
Dr. Mosher?
Yeah, I was just going to sort of piggyback on what Dr. Ensrud was saying. I think that we just have to put ourselves out there and let people know that we have the skill sets that are needed for this field. And for example, when we hired our neuromuscular trained neurologist and he joined our practice, one day he just looked at me and said, "I have never met a physiatrist like you before. Like, I really did not know that physiatrists did all this." And so, I think we have sort of an advertising problem, or maybe we just don't highlight our skill sets enough. But I think it's really important that we are more assertive in this space and become better at advertising our what we have to bring to the table.
One other thing, when you are negotiating or developing a practice, I mean, I worked for quite some time in the VA system, and that was wonderful because the VA just appreciates you for the patient time, and it's not so revenue or billing specific. But the fact is that these patients who have neuromuscular diseases require a lot of rehab services, so they are valuable to a rehab network or a rehab hospital. And therefore, when you're, say, doing a clinic, an MDA clinic, you might be seeing a lot less patients than, say, a sports medicine clinic, but these patients are requiring a lot of therapies and so on. So it's good to realize that, and can be used in negotiating your support as well.
All right, we'll move on to a different question. This was a really, actually, I mean, I'm learning a lot just hearing the answers to these questions, so this is fantastic. Is there an uptick in the number of applicants applying to the neuromuscular match? Is it getting harder? Dr. London, maybe you get the most data on it to share with us.
Well, the data that I shared is from last year, and we have data from the prior year when the AANEM was, first had the portal. But before that, we actually don't have anything. The ACGME keeps track of fellows because most fellowships are ACGME accredited, but they don't share that information with anybody. So we don't actually know if there has been a trend. All we know is that this year and last year, were similar. I think there was a very probably non-significant increase in fellowship applications in 2022 compared to 21. We're hoping that it's going to increase. I mean, part of reaching out to this community is to work towards that. And we're also hoping that having the later timeline will allow more residents to explore neuromuscular medicine during residency before having to make that decision. And that might drive more people towards the field. But the reality is, the only thing that we know is that programs are seeing more applications, but I think that is just because it is a match, right? Before you have a match, people would apply to one place, and if they got accepted, they would not apply anywhere else. And so now people are sort of applying a little bit more broadly. So I think that kind of gives us a false sense that there are more applicants out there. But I think we're going to need a few more years to know if there's really a trend.
Makes sense. Speaking about being an applicant, Dr. Allen, you were our most recent applicant. You succeeded and you found a home. But were there any bumps along the path in terms of being a PM&R trainee? Also, we have to be careful because he's also Canadian, and I can speak from personal experience. It's not a helpful thing when you require a visa to enter the U.S. to get a position. Can make it a little trickier. Places have to really like you to want to interview you and offer you a position. But could you talk to a little bit, like in terms of like any awkward moments being a PM&R based applicant when you were applying, just the previous year?
For sure. That was something I was certainly aware of, approaching the interviews and approaching my personal letter, not really knowing how I was going to be received. But when it came down to it, and I ended up interviewing at 8 different sites, covering sort of most of the geography of the States. It never came up as an apparent like negative or a challenge. No one seemed to struggle to appreciate what physiatry is, or at least the fact that they understood why I was there applying to the program. It did come up in almost every interview in some form. And a lot of times the questions were kind of starting off almost as if, would I perceive any challenges as a physiatry applicant joining a neurology department to do a neuromuscular fellowship? But almost every time before the person finished asking the question, they would add some qualifiers onto that, saying, well, I've seen so many physiatrists come through clinic and they've had obviously lots of EMG experience, and we certainly appreciate all the rehab skills are very valuable in our patient population. So it's almost like they all softened the question to make it not antagonistic. Now, who knows if that's the case when you interview everywhere, but I have to say that it didn't seem to be an issue in my interviews, at least to my face.
Gotcha.
I'll leave it there.
And since virtually all fellowship programs are based in neurology departments, although they may have PM&R faculty.
Yes, I think UC Davis is the only one that's physiatry led, I think.
Maybe it'd be interesting to hear from our current fellow, Dr. Adewuyi, who could comment a bit on what you treat it like when you're finally in a fellowship program as a physiatrist.
That's a great question. I think because they're run through neurology, right? They're designed for neurology residents. And what I mean by that is, as we discussed, a typical neurology resident has done, max 10 EMGs. And so, the first week it's, this is the deltoid, like this is where you stick the muscle in, right? Which, having done over 300 EMGs during residency, that wasn't the level I was at. But on the flip side, in terms of the, immunomodulatory treatments, in terms of just, managing like myasthenic crises or GBS, they come in, what tests do you run? Like, what do you treat them immediately? Like that was a given, which for me, it wasn't. And so I think because of there's that sort of dichotomy there, and so you're, as a neurology resident and as a PM&R resident, you both have your strengths, you both have your weaknesses. And the goal is by the end of fellowship, I think you should be at the same footing. I think whether you're PM&R or neuro, with good fellowship, you both, there shouldn't be a difference. And in speaking with other neurologists and other specialties, like when I do consults or talk with them, some of them don't know I'm PM&R, right? It doesn't come up in conversation. Like when I'm just like, I'm the neuromuscular fellow, like, what's the issue? They have no idea until, you know, later up it comes up and like, oh, huh, I didn't know. So I think it's been going well.
And then maybe Dr. Rad, you now you're working right in parallel, right, with you know, with your position, embedded and working closely with the other neuromuscular specialists. How's that interaction go as this, you know, or let's say early to mid career physiatrist?
Yeah, I think I'm hitting my 5-year. I think this year maybe is the start of it. So again, you know, I think we think of the group as, you know, neuromuscular. There is definitely skill sets. You know, as I moved away from fellowship, I see less myasthenia gravis unless I'm staffing a fellow clinic, and I've inherited all CMT, all SMA, where my neuromuscular colleagues are like, yep, we don't need to see this anymore. So a lot of the diagnoses that, you know, we're capable of diagnosing because we've done a fellowship or are trained. And then the rest of the management is largely rehab. Those become, you know, the bread and butter to me. Going back to the interview trail, and I'm so glad that Dr. Allen had a wonderful experience. We had a recent, you know, we've had recent mentees go and do the interview process, and there have been funny stories shared, you know, like they're in the interview and the neurologist didn't know that they were interviewing a rehab candidate. And so I think having that now, like whether they take rehab or not, is important, because I think that program wasn't taking rehab. I've heard comments on, you know, well, you'll have to get a reflex hammer, you know, so funny, you know. I do think there's an element of, you know, whether it's on us as the trainee, not necessarily that the program puts on you, but an element of feeling like you need to like prove yourself as being able to participate in this type of fellowship. But I think for the most part, most programs understand that there is as everyone has mentioned, you're going to complement each other. You know, they're a good fellowship, which was said, should put you on even playing field at the end. Like once you move away from that, there are things that each one of you is going to bring to the table, and you might, you know, you guys might follow different paths, but you should be able to, you know, easily diagnose and manage conditions. And on the flip side, the neurology residents should come out with ability, you know, to understand how to do rehab treatment for these patients. One of the things I did want to mention is, I'm not sure if it's required from all fellowships, but I know when I was in fellowship, it was expected that I would take my boards afterwards. And so that's another thing, you know, there is rehab questions on the boards in terms of bracing and management and just general management. And so all the fellows are expected to sit for the boards. And so that's just further, you know, further proof that you should be on an even playing field when you're done with it.
Great. Well, listen, I'm going to take a totally different tact here. You don't want to say, for anyone in the audience who doesn't want to do a fellowship, but wants to focus on neuromuscular medicine, what resources are out there after their completed physiatry residency to make sure that they're up to date, to make sure that they're you know, able to take on the toughest clinical cases in the EMG lab or otherwise, if it's necessary. Does anyone want to maybe speak up to some of the resources for continuing education or for augmenting your skills outside of the, you know, a fellowship track?
Gosh, I'll bite as your friendly non-fellowship trained neuromuscular physiatrist. Given that this webinar is hosted by the AANEM, it would be remiss to not mention what an incredible resource the AANEM is, not only for trainees through the training program partnership, which affords a ton of resources at low to no cost for trainees that are enrolled in programs that participate in that program, as well as really fantastic opportunities to keep up on your continuing education to continuously improve your own practice. And if you don't fellowship train, my path in trying to improve my own practice was to aim for my EMG boards a few years out of residency training, and having that goal set out what really compelled me to take my EMG practice to the next level, to pursue ongoing training opportunities through EMG specific conferences like the Ultra EMG course and some other regional courses. And I think those were all helpful for me personally to feel more competent at more complex EMGs and get beyond what I had learned just in my specific training program with the EMGs that I did during my residency. So those would be two resources that I'd recommend.
Great. Dr. Mosher has her hand up.
Yeah, I think there is a lot of really great resources to educate yourself further on neuromuscular diseases. There's cropped up, a whole host of organizations, some of which are disease specific, other which are more general. Resources such as the Muscular Dystrophy Association, Parent Project Muscular Dystrophy, Cure SMA. There are organizations for Friedreich's ataxia and just a whole host of conditions, Charcot-Marie-Tooth Association. So taking advantage of all of the educational opportunities that these organizations provide, and it's really high quality educational opportunities, is just a fabulous resource. And oftentimes they're not very expensive or even free.
Great. Any other thoughts on the topic? Well, I thought maybe we're running short on our time here, so I thought maybe I'd finish on, people like a real rapid fire one. What is the single best thing that's happened to you, having picked this subspecialization, whichever way you get there, in terms of just your job satisfaction? Because I think, we picked obviously a biased group. People are here are pretty happy with their jobs. So, we have to admit that's a bit of a bias here up front, but maybe we'll start with, I got Dr. Howard at my top left. So let's go ahead with Dr. Howard.
Gosh, I would have to say patients are really incredible. It's very gratifying subspecialty.
All right. Dr. London?
I think the cool thing about electrodiagnostics and doing a lot of that is I think it's the only tool in all of medicine where you can have a hypothesis, test it at the bedside, and then get new information that makes you generate a new hypothesis and test that at the bedside and keep honing in on it until you have your answer all, in 45 minutes, which I don't know anything else in all of medicine where you can do that.
I love it. Yeah. Definitely get to the hypothesis testing faster than on the bench. Dr. Ensrud, it looks like you're about to start a cat experiment there. The classic physiology model. Yeah.
Sorry, I've been out of town, and the dogs stay on the floor and the fish stay in the tank.
Okay.
The cats are mobile. And if I hadn't been a physiatrist, I would have been a veterinarian. But the most exciting thing about neuromuscular disease is it's just so dynamic. How could you get bored? It's just rapidly changing and it's complex. And every clinic I go to, I'm like, oh my God, I got to read up on that. I don't know what's changed and everything. So I can't imagine. I'm at the age now where I'm 58 and people are stopping practice. You know, they're retiring from being physicians, and I just can't even imagine doing that because it's so interesting. Yeah.
Awesome. Dr. Allen, I'm just going through, it makes sense on my screen. I don't know if it makes sense to you guys. Which way I'm going here.
Yeah, sure. Yeah, maybe a little bit early days here for me, but and I'd like to say Dr. Howard probably kind of stole my answer there because the patients are obviously very special. But the other thing that jumps out to me is the mentors and colleagues that you meet. I found it's been very, very easy to, you know, make new colleagues, make new friends, people who will give you advice that seems to be in your best interest and are open to helping you out. And it's been a real delight to meet all of those people and including all the people on this panel have helped shape my career in a positive way.
All right, we're gonna go quick here, Dr. Kai.
You know, kind of to reiterate that, you know, I think this is a great patient population to work with. I think this is a great field to work in. You know, everybody from the patients, the parents of the patients, physicians, therapists, you know, everybody in this field is very passionate and, you know, very driven. So it's very meaningful to, you know, make those relationships and to work with these patients. And, you know, it gives you a lot of job satisfaction.
Dr. Rad?
It gets harder as people, you know, steal, take your answers. But I would say, you know, one of the best parts of my job is, I don't know in what other, you know, specialty you actually enjoy walking into the dictation room. And so I love walking into my dictation room where all of, you know, like the neuromuscular, whether you're rehab or neurologist, just start talking about your patients and trying to figure out what they have, from the most senior like colleague who is probably humoring all of us by asking us what we think is going on. Like it's almost an extension of training in the best way possible. You know, like I love going to the dictation room, and, you know, you have this very supportive group, but you're constantly learning. Things are constantly changing, you know, like you'll discover this one family that recently got diagnosed with this genetic condition. And so it's, yeah, I don't know any other specialty or subspecialty where, you know, you are continuing to feel like a resident or fellow, but in the best possible way, like the best possible aspects of that, and being very well supported.
All right, Dr. Mosher.
So I totally agree with the patients. I love the patients, but I just want to sort of take a moment to brag on my colleagues, because I think that the community of neuromuscular physicians is among some of the best human beings that you will ever meet. And I haven't found anybody that hasn't been willing to not only help, but really go above and beyond whenever I've needed advice or assistance with anything. So it's just such a wonderful group to be a member of.
Dr. Adewuyi?
Yeah. Oh, wow. Well, I mean, I certainly echo everyone's sentiment. I will add that, you know, we are in an era of a lot of these new gene therapies and splicing and treatments that are truly remarkable. And it's exciting to be in a field where you have these advances that I think as PM&R physicians, we're going to be seeing patients in 10, 15 years that we wouldn't have seen otherwise, who wouldn't have made it, who have certain rehab needs. And I think that's really exciting. And I'm excited to see where the field goes with that.
Great. And I'll just say, I think it's got to be just, you know, the nerves. You know, people are just a big bag of nerves and thinking about nerves all day long, even if I'm having a bad day, and just thinking about localization and thinking through the physiology and anatomy is always makes me happy. I think, you know, one thing someone told me, if you're as life goes on, sometimes you'll have challenges that'll just make it hard to just want to help other people because you're thinking about what's going wrong with your own life. But if you just love just fascinated by what you're doing all the time. You want to help the people. The patients are great. I get it. Agree with everyone, but just it's always enjoyable to kind of in an escape maybe to think through some of the problems we face. So I just find it that's what does it for me. If I had to add something, I had to think of something different. That going last. So I think we're gonna wind it down here. I believe we got through most of the questions. If anyone needs to kind of follow up offline, there's a few different options. One of the easiest things is if you're at all with AANEM, you can use the AANEM I think connect the chat board. Am I getting it wrong? And submit questions. And I've seen people even from this group here answer questions. Yeah. And that's a great I think it's not too hard to come up with our contact information. I'm first initial, last name at sralab.org. You can reach out. I can connect you. I'm sure most of the panelists we get these messages all the time. So it's great to have everyone together. So we're kind of hearing everyone's perspective, because I often feel nervous trying to speak and give people advice. That's too, overstating how much I know, because I know that the landscape is so different depending on where you're coming from. So that's why it's so incredible that we were able to get this panel together tonight. And we're happy to communicate. I think I speak for all of us in saying that. So the conversation continues, but good luck with your future career decisions, and we're here to support you.
Yeah, just for all the physiatry residents on the call, go forth with confidence, because you have so much to offer these fellowship programs, and you have a lot to offer the patients, and the patients have a lot to offer you. So go forward with confidence. Yeah.
Great. Thanks, everyone.
Thanks, Tom.
Thanks.
Thanks for having us.